like to thank Dr. Ayman and the organization committee for this invitation. It's a pleasure to be among all of you and among the excellent speakers for this session. So gonna talk, I'm a pediatric nephrologist, so I'll touch base about one of the kidney disease, which is very rare and but very important in regard to our country and the region. So primary hyperoxaluria will go through the disease epidemiology and the features and how we manage it and what is the future. So we start with a case as with other speakers. We have a 6-month-old infant with failure to thrive. This actually a case who presented to my clinic from Afghani family. The father and the mother is a first-degree cousins, and usually they have referred by a general pediatrician. So our frontliner is usually the general pediatrician. We did some labs, and we found, interestingly, that the child is profoundly anemic with increase in urea and creatinine. We sent for ultrasound, and as you see in the pictures here, there are severe nephrocalcinosis and renal stones by abdominal X-ray. So it's not rare or not uncommon to have infants or children presenting with renal stones, but it's surprising for the parents because usually they used to hear renal stones in elder or older ages. So we are giving the talk to highlight this important disease and others. The frequency is very common in different continents. In the US, for example, it's about 50% identified secondary to metabolic origin. In our regions in the Middle East and Southeast Asia, it's more common in male than female. And it's endemic in the region because of consanguinities, the weather, and other factors. In the stone-belt area, which is Afghanistan, Iran, Turkey, and Pakistan, it's more of metabolic origin, like underlying genetic causes. There are risk factors which can increase the incidence and the prevalence of renal stones among pediatric populations. One of the most common is recurrent urinary tract infection, abnormalities of the kidney and urinary tract anomalies with the bladder augmentation, for example. Our region with hot weather, less fluid intake, and of course, increase the dietary intake of oxalate will be another reasons. Since we are in a rare disease conference with metabolic and genetic causes, of course, on the top, especially if it started very early in infancy, and among them is the primary hyperoxaluria and oxalosis. So what is hyperoxaluria? As the name or it's mentioned, is an excessive oxalate secretion in the urine, more than 0.5 millimole per day. It could be primary or secondary. So the primary causes, as you see here, it's due to overproduction of the oxalate from the liver. The secondary causes could be due to increased dietary intake or increase in the absorption of the oxalate from the intestine due to defect or change in the microflora. I will not talk too much about the GI because of the moderator. The other cause will be idiopathic. So this will lead to increase in the plasma oxalate, which the kidney will try to get rid of this extra oxalate. But if it's supersaturated or the production is overwhelming the kidney, then we will have kidney stones, and of course, as you will see shortly, declining in the kidney function. There are 3 types of primary hyperoxaluria. The most common is type 1 in 70% of the cases. It's due to enzyme deficiency. All other types also due to other enzymes deficiency, which mainly produced in the liver to organize and to control, regulate the oxalate metabolism. So type 1, as you see, 70% of the cases is due to AGT enzyme deficiency, alanine, glyoxalate, aminotransferase, and the other types are 10% each. I will concentrate and focus on type 1 PH1. How this happened? So the defect usually in the peroxisome of the liver cells. Usually, if you can see here, I don't know if it's the light, but anyway, the glyoxylate usually will give the product of pyruvate and glycine through the enzyme AGT. If we have a defect in this enzyme, then the glyoxylate will give or go to the oxalate pathway through the GO enzyme, which is a glycolate oxidase enzyme. This will lead to more of the oxalate production, which will be secreted by the kidney. There are other enzymes, which, as I mentioned earlier, involved in the type 2 and type 3 primary hyperoxaluria, and will not address it in this talk. So, it's a rare disease. Prevalence is 1 to 3% in 1 million population. It's an autosomal monogenic disorders, usually have different presentation due to different mutations, so the phenotype is variable. If it's progressing, then the kidney is the first to be involved because of the oxalate usually secreted by the kidney, but if the kidney failure happened, then oxalosis and other organ system are involved. This slide is very important. It's highlighting the epidemiology of the PH1 in our region and all over the world. It's about 1 to 2% of causes of end-stage renal disease in different registries across the US, Japan, and Europe. In Middle East and Northern Africa, one study showed that the prevalence is about 10%, and this reflecting high rate of consanguinity. In Tunisia, for example, primary hyperoxaluria accounts about 13% of the end-stage renal disease in pediatrics. In Kuwait, which is more or less similar to our region and country, the PH1 counts for 19% of the causes of kidney stones, 3.5% of the chronic kidney disease in children, and about 10% in end-stage renal disease. So it's endemic in our region, although it's rare. How the child or the infant or the patient will present. It could be very variable according to the age, according to the mutation the child has, but it could be starting from mild asymptomatic or pre-symptomatic if there's a strong family history of the similar disease. So it can show in the screening of the family. Usually the common presentation happens as a recurrent renal stones. It can present with failure to thrive if it's in infancy, hematuria, recurrent UTIs. And if it's usually if present very early, it will be very severe and the child can present or the infant can present with end-stage renal disease. If the disease is progressing and we reach to the stage 4 chronic kidney disease, then there will be more of the oxalate deposition in other systems like the heart, the bone, and the retina, and that cause systemic oxalosis. So this study showed how is the worsening kidney function over time, so highlighting the importance of early diagnosis and recognition of the disease. So the early the diagnosis, the less likely the child or the infant will be having a chronic kidney disease or end-stage renal disease. But regardless of that, at any time, even if we have a stable kidney function, the worsening kidney function can happen over a short time. So this is the systemic oxalosis, which usually starts when we reaching CKD or chronic kidney disease stage 4, and the GFR or the creatinine clearance is below 30 ml per minute per 1.73 meters square. It can affect different organs, including the eye, the blood vessels in forms of ischemia, cerebral infarction, and the bone marrow with profound anemia that not responding to erythropoietin, hypothyroidism, kidneys, and other organs. How we diagnose it? Usually it's underdiagnosed, and there is a delay in the diagnosis for multiple reasons, which I will mention in the next slide. But up to 50% of adults diagnosed with PH1 already have significant kidney disease. 10% diagnosed with PH1 after kidney failure, sometimes after recurrence in a transplant. So it's usually missed. So the delay in the diagnosis usually happen in the adult population. The median age of diagnosis is about 5 years, but usually 50% of the adult, when they diagnose, they already have end-stage renal disease. Why this happened? This is because of the variable presentation. less awareness, less index of or low index of suspicion, limited access to the urinary, metabolic, and other genetic screening, and of course, the infant and pediatric patient often having more overt symptoms. So we, as a pediatric nephrologist or a general pediatrician, need to pay attention to this. So if you can see here, in childhood and infantile age, usually the diagnosis happen earlier than the average in adult population. Again, it's an autosomal recessive genetics caused by AJXT gene mutation, and there are more than 170 mutations reported. So how we approach a child or a suspected case of PH1? So through genetics, it's a rare disease conference. Usually we do targeted mutation analysis as a screening tool for the specific gene which is known and for the disease, but it's sensitive in about 70 to 77% of the cases. If this is negative, then we go for whole exome sequences, and the sensitivity here usually is about 98%. And of course, prenatal diagnosis usually happen by linkage analysis. If all are negative, then the only way to diagnosis is by doing a liver biopsy and assess the enzyme activity. Again, I will move quickly before Dr. Mugdadi is paying any attention. So prenatal diagnosis usually happens by two ways. The first is by taking a liver biopsy under ultrasound guiding in the second semester to measure the enzyme activity. The first will be through chronic villus biopsy for the DNA mutation analysis in the first trimester. How we diagnose, we depend on the clinical features and labs plus radiology. So of course, we do an ultrasound for the kids. So they will have a kidney stone or nephrocalcinosis. If we send the blood, we can see that urine, if you send urine, then in the oxalate in the urine, we start with the oxalate creatinine spot. If it's very high, then we do a 24-hour urine collection to confirm it, which is sometimes challenging in very small infant, but we have a cutoff which we can follow. If there's chronic kidney disease or the infant or the child present very early with the deterioration in the kidney function, then we can send for serum oxalate, which will be high, and of course we can send at the end the genetic test. So kidney is the first organ to be involved, and then all these kids will have a potential for secondary complications, so they need a regular follow-up according to their level of kidney impairment, and that can be running between once a year, every 6 months to every 3 months when it's very advanced stages with different labs and radiology. So early diagnosis is very important because it affects the long-term outcome, and also it will affect the management plan, whether you need to just start with a supportive treatment or target the potential treatment or the novel treatment. Why this is important? Because the early the diagnosis and the early the treatment, the prognosis will be better. And of course, infantile PH1 is the severe form, and mortality and morbidity is more than 50% in the cases. This study showed that it basically showed a retrospective study evaluating a cohort of 27 pediatric patients presented early before they're reaching to the end-stage renal kidney disease. And it showed clearly that the early treatment and intervention will delay the progression of the kidney disease and minimize the risk of oxalosis-related complications. So these are the conventional treatment usually with any child with PH1. Hyperhydration, usually for all the kids. Usually even sometimes we require G-tube or nasogastric tube to overhydrate them, but sometimes it's difficult to achieve that. Alkalinization of the urine is at the second point because, as all of you know, calcium oxalate stones precipitate in acidic urine. Dietary changes of limited use, but still can help. Surgical intervention like removing of the stones by different procedure, whether open or lithotripsy, is another option to remove these excessive stones. And dialysis, if we or the patient presented with end-stage renal disease, it's not the routine dialysis, which is 3 times a week. It usually requires daily dialysis and longer duration because the burden of the oxalate overproduction is too much, and it cannot be removed only in a short session. But the potential when we have an end-stage renal disease, then the transplant will be the last option. And here, if we do a kidney transplant only, then we are not solving the underlying problem, because as we mentioned earlier, we need to do a combined liver and kidney transplant because the defect is in the liver, not in the kidney, which is having better outcome. And it depends on the case by case. So Lumisiran is the first small interfering RNA therapeutics indicated for PH1 to reduce urinary oxalate level in pediatric and adult patients. It is FDA and EMA approved based on 2 clinical trials, Illuminate A and B, and it works by blocking the GO enzymes. So here, as we mentioned earlier, there is a deficiency in graph B, AGT enzyme, which will lead to increased glyoxylate through GO enzyme. So Lumisiran work basically by blocking the GO enzymes, and so that we will not have more glyoxylate, which will be the byproducts of the oxalate. It's very promising, and it's showing a good results in the pediatric and adult population. Tomorrow, I will give a talk more about the RNA mechanism and technique, which change or shifting the gear recently. So in summary, PH is a disorder of glycosylate metabolism characterized by overproduction of oxalate. There are 3 types, and the most common is PH1 in 70 to 80% of the cases. Delay in the diagnosis are common because the primary clinical manifestations are heterogeneous and unspecific. There is also no clear association between the genotype and phenotype. Delay in the diagnosis usually will present the patient with end-stage renal disease. So underdiagnosed case will have a worsening outcome and long-term morbidity and mortality. Depending on the severity of the enzyme deficiency, patient may have end-stage renal disease, whether in infancy or early adulthood. There is a significant unmet medical need for the additional management options for patients with PH1, but Lumisiran is promising treatment. And that I'm ending my talk, and I would like to invite all of you about the upcoming 15th Asian Congress on Pediatric Nephrology, which will be next year here in Dubai in November 2023. And I'm open for a question. Thanks.